Welcome to this lecture on nephrotic syndrome, an important topic in renal physiology and pathology. In this session, we will cover its definition, mechanisms, causes, clinical features, investigations, complications, and treatment in a simple and high-yield way. Nephrotic syndrome is a glomerular disorder, characterized by a classic tetrad of findings. These include massive proteinuria, greater than 3.5 grams per day, hypoalbuminemia, generalized edema, and hyperlipidemia with lipiduria. It results from increased permeability of the glomerular filtration barrier, leading to abnormal loss of plasma proteins into the urine. To understand nephrotic syndrome, we need to briefly review the normal glomerular filtration barrier. This barrier has three layers. Number 1, the fenestrated endothelium. Number 2, the glomerular basement membrane. And number 3, the podocyte slit diaphragm. Together, these structures selectively prevent large molecules, such as albumin, from passing into the urine. Damage to any of these layers can result in protein leakage. In nephrotic syndrome, the primary problem is injury to podocytes and the filtration barrier. This damage allows albumin and other proteins to escape into the urine. As proteins are lost, serum albumin levels fall. Low albumin reduces plasma oncotic pressure, leading to fluid shifting into the interstitial spaces. This produces generalized edema, including periorbital swelling, leg edema, and even ascites. The liver senses the low oncotic pressure and compensates by increasing lipoprotein synthesis, resulting in hypercholesterolium and hypertriglyceridium. These lipids spill into the urine, forming fatty casts and oval fat bodies, a hallmark of nephrotic urine. The clinical presentation begins with edema, which is a hallmark of nephrotic syndrome. Patients may have periorbital edema, especially in the morning, dependent leg swelling, scrotal or vulvar edema, and in severe cases, generalized anasarca urine may appear frothy due to the presence of proteins. Microscopy often shows fatty casts or oval fat bodies, giving the characteristic Maltese cross appearance under polarized light. Laboratory tests show hypoalbuminemia and hyperlipidemia. Patients also become hyperocoagulable because they lose antithrombin 3 in urine, predisposing them to thrombosis such as renal vein thrombosis, deep vein thrombosis, and pulmonary embolism. Additionally, loss of immunoglobulins increases the risk of infections such as cellulitis and peritonitis. Nephrotic syndrome can be classified into two major groups: primary nephrotic syndrome, where the disease originates within the kidney itself, and secondary nephrotic syndrome, where systemic diseases or external factors damage the glomerulus. Let's go through each type in detail. Primary nephrotic syndrome. Primary nephrotic syndromes are caused by diseases that directly affect the glomerular filtration barrier. A. Minimal change disease. The first and most common cause of nephrotic syndrome in children is minimal change disease. On light microscopy, the kidney appears normal, but electron microscopy reveals effacement of podocyte foot processes. This disease is strongly associated with recent infections, allergic reactions, NSAID use, and Hodgkin lymphoma. Importantly, minimal change disease is highly responsive to steroids, making early treatment very effective. B. Focal segmental glomerulosclerosis, FSGS. The second primary type is focal segmental glomerulosclerosis, or FSGS. The word focal means that only some glomeruli are affected, and segmental means only part of the glomerulus is involved. FSGS is common in adults and is strongly associated with HIV infection, obesity, heroin use, and sickle cell disease. Unlike minimal change disease, FSGS often shows a poor response to steroids, and it can progressively lead to chronic kidney disease. C. Membranous nephropathy. The third primary cause is membranous nephropathy, the most common cause of nephrotic syndrome in adults. It is an autoimmune disease associated with anti-PLA2R antibodies. Histologically, it shows thickening of the glomerular basement membrane with the characteristic spike and dome appearance on special staining. Membranous nephropathy may be primary or secondary, and it often presents with severe proteinuria. Membranoprophyphyive glomerulonephritis, MPGN. The fourth type is membranoprophyphyive glomerulonephritis, also known as MPGN. This disease presents with features of both nephrotic and nephritic syndrome. Type 1 MPGN is associated with hepatitis B and hepatitis C infection, while type 2, also called dense deposit disease, results from complement secondary nephrotic syndrome. Secondary nephrotic syndromes occur due to systemic diseases, infections, medications, or malignancies affecting the kidney. Diabetic nephropathy, the most common cause of nephrotic syndrome overall, is diabetic nephropathy. Long-standing hyperglycemia leads to thickening of the basement membrane, mesangial expansion, and formation of Kimmel-Steele-Wilson nodulus. Diabetic nephropathy progresses gradually and is a major cause of chronic kidney disease. B. Lupus nephritis, Class V. Another important secondary cause is systemic lupus erythematosus, specifically Class V, also called membranous lupus nephritis. Immune complex deposition in the glomerulus causes nephrotic range proteinuria, often accompanied by other signs of lupus. Amyloidosis is another systemic disease that causes nephrotic syndrome. Amyloid proteins deposit in the glomeruli, damaging the filtration barrier. A classic finding is Congo red positivity, showing apple-green biofringence under polarized light. Infections. Certain infections can also cause nephrotic syndrome. These include hepatitis B, hepatitis C, and HIV. HIV-associated nephropathy often leads to a severe form of FSGS, known as collapsing variant, drugs and toxins. Several medications are known to cause nephrotic syndrome. The most common include NSAIDs, penicillamine, gold salts, interferon, and lithium. These drugs typically cause podocyte injury or immune-mediated glomerular damage. Malignancies. Finally, some cancers can trigger nephrotic syndrome. Hodgkin lymphoma is classically associated with minimal change disease. Solid tumors, including lung and colon cancers, may lead to membranous nephropathy. Summary. In summary, nephrotic syndrome can arise from primary glomerular diseases, such as minimal change disease, FSGS, membranous nephropathy, and MPGN, or from secondary systemic conditions like diabetes, lupus, amyloidosis, infections, medications, and malignancies. Understanding these types helps guide diagnosis, management, and prognosis for patients with heavy nephrotic syndrome can lead to several important complications. Number 1. Severe edema, which can progress to anasarca. Number 2. Thromboembolic events, especially renal vein thrombosis, deep vein thrombosis, and pulmonary embolism. Number 3. Infections due to the loss of immunoglobulins and complement proteins. Number 4. Acute kidney injury, which may occur from hypovolemia or drug toxicity. Number 5. Accelerated atherosclerosis, driven by chronic hyperlipidemia. Management begins with general measures. Salt restriction and fluid control help reduce edema. A moderate protein diet may be recommended depending on kidney function. Diuretics such as furosemide or spironolactone help mobilize excess fluid. ACE inhibitors or ARBs reduce proteinuria and protect kidney function. Statins are used to treat hyperlipidemia. Steroid therapy is the treatment of choice for minimal change disease and may be used in some cases of Other immunosuppressants, such as cyclophosphamide, tacrolimus, cyclosporine, or rituximab, may be required depending on the underlying cause. Anticoagulation is indicated if thrombosis occurs and higher-risk patients may require prophylaxis. Finally, vaccinations, especially pneumococcal and influenza vaccines, are recommended due to increased infection risk.